Good afternoon, all of you. First of all, I would like to thank the KSOS Scientific Committee and Cinemol Madam for giving me this opportunity. Here I am talking about non-device options in small pupil. So the goals of pupil management in cataract surgery is to achieve adequate pupil size for the cataract surgery and also to maintain good pupillary function as well as cost basis. The key factors for this process can be divided into 3 steps: preoperative assessment, pharmacological and non-pharmacological methods. Preoperative assessment is very important because we should identify the patients who are at risk of developing small pupil during surgery. Previous history of trauma or uveitis, those who have PXF, those who are on treatment for BPH and diabetes, we should identify. Avoid dilatation 1 to 2 hours before the surgery and stop any miotics 3 weeks prior to surgery. Preoperative medications, we usually use topical mydriatic and cycloplegic like T+. NSAIDs can be given 30 to 90 minutes before surgery. They inhibit prostaglandin release. Atropine eye ointment has been found to be beneficial in few cases of floppy iris if given 2 to 3 days prior to the surgery. Surgical sponge soaked in 10% phenylephrine can be kept in the inferior fornix 30 minutes before surgery. Coming to the intraoperative methods, these include intracameral drugs and various devices. The intracameral drugs have the advantage that they don't have any adverse systemic side effects and they have direct contact of the drug with the target tissue. Coming to the pharmacological methods, the first one and the most commonly used one is epinephrine 1 mg per ml, 1:1000 solution. 0.1 ml is mixed with 0.9 ml of BSS and to make it 1:10,000. Second method is also using epinephrine, but we mix 0.5 ml epinephrine in 500 ml of BSS. The advantage is that the concentration of the drug is not lowered during the procedure and only a lower dose of drug is needed than a single initial injection. Next method is using 1% preservative-free lidocaine injected into the anterior chamber. This causes topical anesthesia of the sphincter pupillae and the dilator become uninhibited. The next method is a combination of tropicamide, phenylephrine and lignocaine, which is now easily available in commercially. 1.5% phenylephrine intracameral is another option. Episugarcaine is a combination of 9 ml of BSS, 3 ml of 4% lignocaine and 4 ml of epinephrine. Omidria is another method. It is a combination of 1% phenylephrine and 0.3% ketorolac. This can be added to the irrigating solution. This doesn't add to pupil dilatation, but it can prevent pupil constriction. This improves intraoperative and early postoperative patient comfort also. Now, in order to maintain dilatation, we can add 2 drops of 10% phenylephrine in 1 to 2 ml of BSS or 0.5 ml of 2.5% phenylephrine and dilute it with 1 ml of BSS. Coming to the non-pharmacological methods, first one is the viscomydriasis. It was described by Dr. Robert Osher. Here OVD is injected at the pupillary margin and the iris is pushed towards the angle of the eye. The only problem is that the effect is short-lived and the OVD has to be replenished in between. Helon 5 or Helon GV is used for the purpose. Always use the topical anesthesia and mydriatic first, followed by viscomydriasis for better results. Next option is the synechial release. If the patient is having any adhesions or the synechiae, it has to be released prior. Iris spatula or a blunt instrument is used for the purpose. Perform lysis prior to pupil dilatation. Helon 5 may be used later for the dilatation of the pupil. If there are any membrane adherent to the pupillary area, it has also to be released. Using capsulorhexis forceps is better. Carefully tear away the membrane from the pupillary margin. Avoid causing iridodialysis and injury to the anterior lens capsule. Some amount of bleeding is expected during this procedure. Another option is multiple sphincterotomies, usually 6 to 8 in number. They should be equally spaced, 0.5 mm extending into the pupillary sphincter. Avoid too much extension into the iris trauma as it can result in permanent mydriasis. Stretch pupilloplasty is another method. This is done using Coughlin hook or Y hook. The instruments are introduced through the side ports and the pupillary margin is hooked and stretched 180 degree apart towards the limbus. The same procedure is repeated 90 degree apart. This produces micro tears of the sphincter and allow for greater dilatation. Next is the Beeler device. It is a one-hand device which produces 3 to 4 point stretch of the pupil. It has 2 and 3 pronged version which can be inserted to 2.5 mm and 3 mm incisions respectively. Here, the Beeler device is inserted through the main incision. The first hook wraps around the subincisional pupillary margin and then upon pushing the plunger, 3 more hooks emerge. they hook the distal pupillary margin. So in one stretch, the entire pupil become dilated. The velar pupil dilate, distribute the tension uniformly throughout the pupillary area so that it will not produce any pupillary deformities. Patient will have a better cosmetic effect after the surgery. The precautions include, while you introduce and remove the device, the proximal hook should always be inserted and removed sideways, otherwise it can damage the corneal incision. Also be careful not to injure the anterior lens capsule. So, for a small pupil dilatation, the stepwise approach include, first go for pharmacological methods, and if not responding, go for viscometriasis. Always go for a synechial release or membrane release if it is there. Pupil stretching and velar device comes next. If nothing is responding, go for pupil expansion devices like rings or hooks. Thank you for your kind attention.
Thank you, Dr. Reshmi, for the informative talk. We'll have a discussion towards the end of the session. Next, Dr. Srini. Okay. He's our scientific committee chairman. Okay. So, which pharmacological method do you prefer, Dr. Reshmi?
I prefer epinephrine. Epinephrine, 1 mg per ml.
What is this omidria?
It's a combination of phenylephrine and ketorolac that is added to the irrigating solution in order to maintain dilatation.
Is it available here?
Not it is just introduced one, not commercially available here.